inviting me to present. Like Jenna said, there we go. Jenna said we're going to talk a bit about genetics in general and pancreas cancer and how that relates. And so just to give you guys a little bit of information about what we're going to talk about today. So I'll do some background about genetics in general. I'm not sure how much background everybody has. We'll talk a little bit about the difference between hereditary and sometimes what some people might hear through treatment about tumor genetics, what we look for when we're evaluating families for hereditary cancer syndromes, what genes are currently known to be associated with pancreatic cancer, as well as we'll talk a little bit about what we call familial pancreatic cancer, as well as risks to family member and is there any screening, and then we'll talk more specifically about being referred for a genetic counseling session and evaluation and how to go about doing that. So I appreciate that there's people from sort of all over. The talk is mainly hits on sort of Canada and the US. So anybody from outside of there, I certainly can direct you to some other sources for you as well. So just a little background on genetics. So your genes are basically instructions for your body. They tell you how to grow and develop and function properly. And all of our DNA is contained in almost every single cell in our body, and it's contained into these little packages we call chromosomes. We have 23 pairs of chromosomes, or 46 total, and you get a copy of each chromosome from one of your parents. So you have 2 copies of every chromosome, and along these chromosomes we find approximately 20,000 different genes. And your genes encode proteins, and proteins are basically what do the work of your cells and the rest of your body. So you can think of your genes like the brains and your proteins like muscles. And all of us basically have the same DNA, but we're all a little bit different. So there is quite a bit of variation between all of us. So everybody has millions of changes in their DNA. Most of that is just common benign variation. It doesn't cause us any problems. It doesn't lead to disease development. It's just what makes us all different from each other. But sometimes people can have changes in their genes that alter how the gene actually functions. And so when that gene typically would encode a normal protein, if there is a mutation or a pathogenic variant within that gene, it can lead to an abnormal protein or no protein being developed. And this abnormal or missing protein is basically can lead to disease development or being at an increased risk for certain types of diseases. To go over inheritance just a little bit, there are several different forms of inheritance. The 2 I'm going to hit on are what we call autosomal dominant and autosomal recessive. There's certainly other types, but the ones that are most important for hereditary cancer syndromes are these 2. Autosomal, all that really means is that the gene change is on one of the first 22 pairs of your chromosomes. The last pair of our chromosomes determine our sex. Most hereditary cancer syndromes are not sex-linked, so I'm not going to go over that. The first one, most hereditary cancer syndromes are dominant. And what that means is you just need to have a change in one copy of your gene to be at an increased risk for disease development. And so what that means is there's a 1 in 2 or 50-50 chance of inheriting a gene change and potentially being at an increased risk for whatever disease we're talking about. So with dominant conditions, typically what we would see is people affected with the disease in each successive generation. So it looks like something's being passed down from parent to child. On the other type of inheritance that's important with hereditary cancer syndromes is what we call recessive. And what that means is that each parent actually has a change in one copy of their gene. We call these people carriers. people who are carriers often do not express the disease. The other working copy of the gene makes up for the one that has the change in it. So typically parents aren't affected. And to be affected yourself, you have to inherit a change from both copies or from both parents. So what that means is there is a 1 in 4 chance with recessive diseases to be inherited. And with recessive diseases, because the parents are typically carriers and not affected themselves, we wouldn't see people diagnosed in successive generations. You might just see one person within a sibship or just siblings affected with the disease. So it's a little bit different than dominant. So sometimes people can think of recessive diseases as skipping generations. Doesn't really skip, it just is when the people are carriers, they don't have the disease, but the gene change is still there. Okay. Moving on specifically to some information about cancer genetics. So all cancer is genetic, but not all cancer is hereditary. And what I mean by that is all cancer is caused by changes in our genes. These mutations or pathogenic variants in certain genes. If they are in genes that affect how our cells grow and divide, or when our cells are supposed to normally die, cells can grow out of control, which is what cancer is. And these pathogenic variants are either acquired or inherited. Acquired means that it's caused by some external or internal factor. It could be aging, things in our diet, environment, behavioral things such as cigarette smoking, medical risk factors, and other things as well. But sometimes pathogenic variants predisposing to cancer can be inherited, and they're only inherited if they're in what we call our germline. And our germline are basically our sperm and our egg cells. So they're only passed on because that's what's passed on to offspring. So just to reiterate this point a little bit more, germline mutations, like I said, are heritable. So they are mutations that are in our egg or our sperm cells. So they are present at the moment of conception. And so when an embryo or fetus develops, that change is actually in every single cell in our body, including our sperm and egg cells, so can be passed on. Whereas acquired, or what we call somatic or tumor genetics, they're not present in our sperm or egg cells at conception. And so whether it's external or internal factors in our body, a pathogenic mutation can be acquired, say, in a pancreas cell. And then every daughter cell that develops from that cell will have the pathogenic mutation in it, and it's only in those daughter cells from that where the tumor mutation would be. So again, not in our germline. So when we think about acquired versus germline mutations, and we think about cancer in general, most cancer is caused by these acquired pathogenic variants. So we group it into this largest category as sporadic. So the majority of cancer is sporadic, meaning it's not hereditary in nature. We blame a lot of this stuff on those external factors. A smaller portion of the pie is what we call familial cancer. Familial cancer, typically we define as a clustering of similar types or the same type of cancer within a family. That would be more than what we would expect just from background rates. And the familial part of the pie, we don't actually have a known gene identified that is predisposing to those diseases. And in this familial piece, because we don't know the specific cause, it's probably multiple different factors. It could be genetic, that we just haven't identified the gene for yet. It could be shared environment among family members, or it could be an interaction of both, so both genes and environment working together. And then the smallest piece of the pie is the actual inherited or hereditary cancer, which only accounts for about 5 to 10% of most cancer types. So these are the known gene mutations and things like some people have heard of BRCA1 or 2 or Lynch syndrome, where we know what the gene is, we can do testing for it, and families can be evaluated for that known gene mutation. So when we're looking at a family to evaluate whether or not they could have a hereditary cancer syndrome, there are certain flags that we look for when we're evaluating a family. So one of the most common things we see with hereditary cancer syndromes is that people are diagnosed at young ages. Typically, we use the cutoff of age 50. We can see people with the same or related types of cancer in successive generations. So it looks like something's being passed down from parent to child. So if you remember, I told you most hereditary cancer syndromes are dominant, but not all of them. Sometimes people can have multiple primary cancers. So somebody could have bilateral breast cancer or breast and ovarian cancer. So that's a flag, as well as there are specific types of cancers that are typically very rare. And so when we see them, we automatically think somebody might need to be evaluated. An example of this is male breast cancer, which in the general population is very rare, but can be seen with some of the genes that we know about. As well as there are certain mutations that might be a bit more common in certain ethnic groups or isolated populations. We call these things founder mutations, so they might be a little bit more common in certain groups than just the general population as a whole. And I will touch on that in a second. Oops, excuse me. So just to show you some very typical families, and I will preface this that most families with hereditary conditions may not look like this at all. So this family here, you can see that there's multiple people diagnosed, some with the same types of cancer, colon cancer here. People are diagnosed at younger ages. There's multiple generations affected. So this is a very typical pedigree or family history that we would see in something called Lynch syndrome, which is a hereditary colorectal cancer condition. And then over here is very similar for hereditary breast and ovarian cancer, typically caused by a BRCA mutation, where you see multiple women diagnosed at young ages with breast and ovarian cancer in multiple generations. I know everybody here is probably very well versed about pancreas cancer, but I just wanted to preface this a little bit before I started going into specifics. Pancreatic cancer is a less common cancer than, say, breast or colon or prostate. It's the 4th most commonly diagnosed cancer in Canada and the 4th leading cause of death. The general population rate is 1 in 76, or about 1.3%, with a median age of around age 71. So it typically happens at older ages, but we certainly can see younger people. Whoops, hang on. And then there are multiple different types of pancreatic cancer, and what this subsequent stuff is going to focus on is the most common type of pancreas cancer, which is called pancreatic ductal adenocarcinoma, or PDAC. So if you see that abbreviation, that's what it is. This is the most common type, but there are other types that I'm not going to cover in this talk. The second most common type is something called a pancreatic neuroendocrine tumor, which I'm not going to touch on here. So I hope everybody is okay with that. So there are quite a few known non-genetic risk factors for pancreatic cancer. The most common is cigarette smoking. We know that it's been validated over and over through multiple independent research studies. There are other risk factors are less validated. There are certainly quite a few studies showing a risk with longstanding diabetes, as well as chronic pancreatitis, and having a high BMI. And the one thing to keep in mind as we're talking about pancreas cancer genetics is that if you do have a genetic risk factor for pancreas cancer and have some of these other non-genetic risk factors, it can increase your risk a little bit higher than what we would see for somebody who, say, is a non-smoker, doesn't have diabetes. So one thing I didn't mention when we were going through the cancer genetic stuff is typically every hereditary cancer syndrome has one major type of cancer seen with it. And then there's increased risk for other types of cancer. So it has what we call a tumor spectrum. So just as an example, and I'll go through this as well, the BRCA genes mostly cause female breast cancer. But we can also see increased risk for male breast, prostate, ovarian, and pancreas cancer. All those other risks are not as high as the female breast cancer risk, but we see a whole spectrum with most hereditary cancer syndromes. So the gene where pancreatic cancer is the #1 cancer scene is actually currently unknown. But we do know that pancreatic cancer is within the tumor spectrum of several genes that are very well known. And you've heard me mention some of these before, and some of you may be quite familiar with some of these. So there's an increased risk for pancreatic cancer with certain breast cancer genes, most commonly BRCA1 and 2. There's another gene that works in the same pathway as BRCA1 and 2 called PALB2. So all of these genes mostly cause female breast cancer, but there's between a 3 and a 7% lifetime risk of developing pancreatic cancer, depending on which gene the mutation is found in. There are colon cancer genes. So you heard me mention something called Lynch syndrome before. Lynch syndrome is caused by pathogenic variants in either one of 5 different genes. Mostly causes colorectal and uterine cancer, but there is an increased risk for pancreatic cancer associated with Lynch syndrome. The risk is again variable based on which gene the mutation is in, so it's really gene specific. There's an extremely rare condition called Peutz-Jeghers syndrome caused by mutations in STK11. This is very rare. It tends to cause people to get lots of polyps in their GI tract, typically starting as teenagers. It's pretty, like I said, rare, but easy to identify in some families, which does carry an increased risk for colon, breast, and pancreas cancer. There is a gene that causes hereditary melanoma called CDKN2A. Typically what we see with CDKN2A mutation families is people diagnosed with multiple primary melanomas, often starting at young ages, could be teenagers, 20-year-olds, depending on sun exposure. There is a common mutation in CDKN2A in certain populations that has been estimated to have a 17% lifetime risk of developing pancreas cancer. And there are genes that cause hereditary pancreatitis. So this isn't your typical tumor suppressor gene, meaning the mutation in the gene itself doesn't cause an increased risk for pancreas cancer. What happens with these genes is that you're predisposed to developing pancreatitis, sometimes often starting in childhood, and you get recurrent bouts of pancreatitis throughout your life, which can lead to chronic pancreatitis. And that damage from the chronic pancreatitis then increases the risk for pancreas cancer as we get older. And Some of the genes carry up to a 50% lifetime risk, depending on the level of damage from the inflammation. And these genes, they really do cause a lifelong risk for recurrent pancreatitis. So it's not sort of just a one-time acute attack, it's something that is really lifelong. And there are certainly other genes that have been implicated in to have an increased risk for pancreatitis, and a lot of them are included in some of the gene panel testing that is done today. But some are newer associations. They don't have risk estimates associated with them yet, and some definitely need to have more research validations before we can comment fully on their role in the development of pancreas cancer. So when we think about genetic testing in people and families with pancreas cancer, if you recall back to the pie, our overall detection rate in what we call unselected, so family or people with pancreas cancer that we're not taking into account their age, their family history, anything like that, the overall detection rate is between 5 to 10%. Certainly family history will affect that, but it's just another point to point out that most cancer is not hereditary. The most well-described gene associated with pancreatic cancer development is actually BRCA2. So that's that breast and ovarian cancer gene. And we've done studies in the past that show, and other studies from other groups around the world that show, sometimes between a 5 and an 8% pickup rate of BRCA1 and 2 mutations in unselected pancreatic cancer. There are common BRCA mutations in people who are of Ashkenazi Jewish descent. And when we look for those specific mutations in people with pancreas cancer, our uptake or detection rate goes up to about 12%, so almost doubling it. Pickup rate for some of the other genes that we talked about is less than 1%. So it's BRCA1 or BRCA2 is really the most common thing that we identify. So here's just a couple of families to show you. This is a family that's very consistent, looks like those quintessential pedigrees I showed you earlier. This is a patient who is diagnosed with pancreas cancer at 58. Definitely looks like your standard hereditary cancer family where you have people diagnosed with the same types of cancer, breast, pancreas, at young ages, multiple primary tumors. And this person was identified to have a BRCA2 mutation. They had a cousin who also had pancreas cancer, who was confirmed also to have that BRCA2 mutation as well. So this is very standard. If a family like this were referred to genetics, most likely they would get testing. But our group, as well as many other groups around the world who've been testing more and more families with pancreas cancer, have seen that up to half of the families or patients that we test may not have a family history that is consistent with BRCA or some of the other genes that we identify. So this is just an example. This is a person who was diagnosed at age 63. They have quite a large family. There is some cancer, but some sort of more typical, maybe behavioral sorts of things with lung. Prostate cancer is quite common in men, so no breast or ovarian cancer in anybody that was reported, and a BRCA2 mutation was picked up. So even if there isn't a family history, it doesn't mean for sure that there's no mutation there. Moving on to what we don't know, there are a group of some of our families that we define as having familial pancreatic cancer, or FPC. If you remember, that middle piece of the pie is where we have clusterings of people in a family with the same types of cancers, but an unknown genetic explanation. So this is an example of a family where we see, so we have 4 individuals in successive generations, all with pancreas cancer. And some of them are very, very young. So we have people in their 30s and 40s, some people at an older than average age. And so this is what we would call familial pancreas cancer, which the definition is that there are at least 2 first-degree relatives, meaning parents, siblings, or children with pancreatic cancer. And many studies have found that about 10% of new diagnoses will meet this criteria. So somebody who's diagnosed 10% of the time, they have a close family member who's also had pancreas cancer. And this group of families certainly is quite helpful for research when we're looking for genes for pancreatic cancer, but it should be pointed out that a lot of families that meet FPC criteria, it's probably, or even the FPC as a whole, it's not going to be one specific cause. There could be multiple different genes involved. It could be shared environment, coincidental. If we took away these 2 young diagnoses and just had 2 siblings, one at an older age, it might be coincidental. So FPC, the explanation for these, this group as a whole is not going to be one thing. It's probably going to be multiple different things. And even if a family meets FPC criteria, it doesn't necessarily mean for certain that there is a hereditary component going on. So, you know, if any of you have families that are in a family that meet certain criteria, I'm sure you're wondering what the risk to yourself or other family members might be. This is maybe small and a bit busy, but this is a table that was published quite a few years ago, but I really like it because it shows the sort of factors that we should take into mind when we think about our own risk, depending on family history. So the things we really need to keep in mind is how close of a relationship are you to that person with pancreatic cancer, as well as how many family members do you have with pancreas cancer. So if you remember, the background general population rate for pancreas cancer is about 1.3%. So if you have a more distant relationship, 4th degree, 3rd degree is a cousin, 2nd degree would be grandparents, aunts, or uncles. So if you have just a grandparent or an aunt or an uncle or a cousin, it actually doesn't significantly increase the risk for pancreas cancer, so 1.4 to 1.7%. So slightly higher, but up to maybe a 6% lifetime risk, so still quite low. But if you start adding multiple 1st-degree relatives, so if you have 2 siblings or a sibling and a parent, those risks can certainly go much higher depending on the number of relatives. I wanted to go through this because, you know, we do have some screening tests for certain types of cancers. We have mammograms and pap smears and stool tests and colonoscopies for colon cancer. But there actually isn't a lot of screening for other types of cancer. So that's 3 different kinds. And maybe besides self-skin checks for skin cancer, we don't have a lot of good screening tests. So this is really what, say, provincial cancer agencies or national cancer agencies, health agencies are thinking about when they're developing screening tests or adopting a screening test and providing that to the public. One thing to keep in mind is the disease itself. So the disease should be common, have treatment, and that the potential for cure increases with earlier detection. And certainly every type of cancer meets that criteria, including pancreas cancer. So then we really have to go down to what the test actually is. And there are certain factors that make a good screening test. So the test should be able to identify a high number of cases before symptoms start. It should be safe to administer, it should be cost effective, it should be shown to improve the outcomes of the disease in those patients, as well as be widely available. And this is sort of where we're lacking with pancreatic cancer screening at this time. Pancreatic cancer screening, there's actually no currently known clinical effective screening modalities, whether it's imaging or blood tests or anything like that. And so there aren't, specifically here in Canada, there aren't any provincial guidelines from any of our cancer agencies promoting pancreatic cancer screening. In the US, there are some different cancer groups that put out information about pancreas cancer screening, as well as places in Europe and elsewhere. But really right now, all of the recommendations are based off expert opinion, as opposed to this, evidence-based demonstrates improved outcomes. So it's really what people think should be done. And there's a group called CAPS. It's the Cancer of the Pancreas Screening Study that's been going on for quite some time. And they put out international guidelines, and it was most recently updated back last fall of 2019. And they define high-risk individuals, so people from familial pancreatic cancer families, as well as individuals with certain gene mutations. And basically their recommendation is saying that if you were going to screen people, it ideally should be done at a high volume center under research protocol. And the reason for that really is to generate enough data to help us prove whether certain imaging or blood tests are effective. We need thousands, if not tens of thousands of people, and to have a uniformity of the screening protocol and to collect all of that information and integrate it from groups all over the world is really what we're going to have to do to really help us learn about the best way to screen for pancreas cancer at this time. Like I mentioned earlier, every country and province may have different recommendations, may have different research protocols open. So I can't tell you specifically what's happening in your area, but certainly as we move on to talking about the genetic counseling or genetics appointments, that's something that people in those clinics should be able to inform you on. So moving to the sort of genetics referral, genetics appointment, that sort of thing. So like Jenna said, I am a genetic counselor. She's training to be a genetic counselor. There is a big need for more genetic counselors in the world with all the new technology that is coming out. So that is fantastic. So genetic counselors are basically members of the healthcare team who have advanced training in medical genetics and counseling patients about recommending tests, interpreting test results, how things are inherited, interpreting family and medical histories. We're patient advocates a lot of the time. A lot of us are educators, so training new counselors in training programs. And then a lot of genetic counselors are also part of research teams, which is a big role that I have and have had in my experience. So when people are referred to a genetics clinic, you might see only a genetic counselor, you might see a medical geneticist, you might see both. And there's some pretty standard things that will happen during that session. So you'll get a risk assessment based on your personal and family history. A review of medical records might be done. Oftentimes it's very helpful to have the records for the cancer diagnoses in the family, just to confirm histologies as well as ages, things like that. There'll be some basic genetics education, discussion of different testing that's available, as well as information about, like I said, about cancer screening, whether it's pancreas or other types, as well as a discussion about how testing could impact yourself and other family members. And one of the things that I think is really important, especially for families that have a known gene mutation identified, sometimes people may be apprehensive about going or may not want to have genetic testing. I think the most important thing is even just going and seeing a genetic counselor doesn't mean you have to undergo that genetic testing. You can go, you can get all of the information. Doesn't mean you have to do the genetic testing, but it is really helpful, I think, to meet with an expert team to give you more information that you may have not had before and provide screening. And on the opposite end of that, I think it's also important to keep in mind that even if you are referred for genetic counseling, you may not be offered genetic testing depending on different criteria that different places in the world have, and we'll touch on that in a second. So who should testing start with? Ideally, genetic testing is most informative when it starts with somebody who actually has the disease that you want to be tested for. So in this context, pancreas cancer or cancer in general. And really the reason for that is if you have a genetic test result from somebody who has cancer, it gives context to interpreting results from somebody who's unaffected. And this is just an example I put over here. This is a person who was referred to me. He was unaffected but referred because of his family history of pancreas cancer. He had a father who was diagnosed, as well as a sister who was recently diagnosed. And she had actually had a breast cancer previously. If you remember from a few minutes ago, there are certain BRCA mutations that are a bit more common if you're Ashkenazi Jewish. And he actually did meet Ontario's provincial criteria to get testing for those common Jewish mutations. But I talked to him and I said, you know, if we do the testing and you test negative, it's hard for me to tell you what your specific risk for pancreas cancer is because, whoops, and that went up too early. But basically, we don't know how to interpret a negative result because I don't know if his sister had been tested, if she hadn't had a mutation identified, then his risk is, if we go back to that table, maybe 8 to 12% because he has 2 first-degree relatives. But if his sister had testing, which she did, we can attribute probably both of her diagnoses to this BRCA mutation. Can't say for certain that dad had this, but we could reasonably assume that he did. And so now this man's negative test is actually very informative negative. And what that means is that because we sort of know what's causing the pancreas cancer in the family, and because he does not have it, his risk isn't 8 to 12%. It's background risk. It's only 1.3. So it can provide clarity when interpreting negative results. That being said, you know, testing certainly can be available to people who aren't affected at this time. There are guidelines in the United States that say, well, they're recommendations, not necessarily guidelines, that say every individual with pancreatic cancer, as well as every first-degree relative of somebody with pancreatic cancer, should be offered testing. And coverage will really be based on their insurance status in the US. So even if you aren't affected, how do you get referred? The best thing to do is speak with your family physician about a referral to a local genetics clinic. They often will know where where the closest genetics clinic is, but if they don't, I have some resources for you guys to look up. When you do get referred, it's very important to know your family history. talk to your family members and ask about different cancer diagnoses, the ages at diagnosis. One really important question is to find out if anybody else in the family has actually already had genetic testing, because those results could be very helpful in the risk assessment. Here in Canada, most provinces have eligibility criteria that need to be met before coverage, before testing is covered under provincial healthcare. But different places will be different. Certainly, like I said, in the US, there it might be on insurance coverage. In Europe, there's probably national health recommendations, and Jenna, I know she's training there, so she probably will know the answer to that.
Yes, I actually looked up the NHS guidelines before this in case anybody from the UK has a question about it afterwards.
Fantastic. And there are things called direct-to-consumer testing, which I'm sure all of you have seen ads for, things like 23andMe and Ancestry. I would say it's very, be a little bit wary about some of those companies. What they're testing for and the level of medical grade testing is very different. And I would encourage you to seek out a proper genetic counseling referral before dabbing into direct-to-consumer testing. And for some of these places, even if you don't meet criteria for genetic testing, there certainly could be research to enroll in, especially if there's screening protocols open in different places. So it is, even if you're not tested, it is helpful to go and speak to the genetics experts. The benefits of genetic counseling and testing for patients specifically, it could impact treatment. There are certain genes that could impact things like chemotherapy or eligibility for clinical trial enrollment. For some of these genes, say BRCA, there could be other cancer surveillance that needs to be done. So increased breast cancer surveillance. There could be risk-reducing prophylactic surgery. Again, as BRCA is an example, women are often encouraged to remove their tubes and ovaries after child bearing. There could be chemo prevention. And then again, like I said, there could be participation in research. So it's really just gaining more information to properly manage your risk. And I will end on this. So if you, I wish I would have added in more, but if you need help in finding a genetics clinic, it's actually relatively easy here in Canada and the US. Here in Canada, we have something called the Canadian Association of Genetic Counselors, and their website is here. On the homepage, there is this nice little button that says search for a genetics clinic. You can just click on that and type in your town or your city. You can search by specialty. You can search the whole province. It will pull up the genetics clinics for you. And then the US society is called the National Society of Genetic Counselors. Their website is here, and on their homepage, there's this icon that you will see that says find a genetic counselor. You can click on that, type in your zip code, it will pull up the closest genetics clinic to you as well, and you can filter by specialty and everything like that. So it's relatively easy to find clinics in North America. There are lots of European societies of human genetics that I reach out to them all the time when I'm looking for clinics in specific countries. So, and Jenna may be able to tell us a little bit more, not just in the UK, but mainland Europe, about access to clinics there too. So I will end there, and thank you, Jenna, and everybody listening, and I'm happy to take questions.